Welcome everyone to today's webinar, Improving Drug Measure Performance, New Strategies for a Changing Landscape. We will start with a little bit of housekeeping. We're going to want this to be an interactive session. There is a Q&A box or a chat box. We will be monitoring both of those. Please submit questions as you have them. We will try to answer questions in flow of the webinar, but we'll also save a little bit of time at the end to answer any that maybe aren't directly relevant to what we're talking about at a given time. But please feel free to ask as many questions as you'd like. We will send follow-ups of the webinar. You will get the deck also. So all this will be posted on the website, on the Lilac Software website. You also get an email with information and links to all this good stuff. So you can share the webinar, you can share the notes, you can share the deck with colleagues, with other people in the industry that you think might benefit from seeing any of the materials or the webinar itself. And then lastly, there is a survey. We love feedback. Let us know what you like. Let us know what we can do better. Let us know if there are other topics that would be of interest for us to cover in a future webinar. So please, filling out the survey will be greatly appreciated and help us deliver more relevant and interesting content for you. All right, before diving into the content, let's introduce our panelists for today. First, we have Mark Ryan. Mark is Lilac's Chief Solutions Officer. Prior to Lilac, Mark was the president of MHK, which you might know as MedHawk. He was there from the very early days and helped turn that into the company that it is. Prior to MedHawk, Mark spent a lot of times as an operator in health plans. He helped launch 2 different Medicare Advantage plans. And then he also experienced healthcare from the policy side when he was the budget director of Connecticut. So brings a very well-rounded view of all things healthcare and brings that expertise to drug measures in particular. Welcome, Mark, and thank you.
Thanks very much, Alex.
Next, we've got Neetu Rajpal. Neetu is Lilac's fearless leader. She is the CEO. Prior to Lilac, she was CTO of Oscar Health. And then before that, she's had a long career of building enterprise software, spent over 15 years at Microsoft, and has worked at every part of the sort of enterprise technology stack, from APIs to front-end applications to a lot of different types of middleware. So welcome, Neetu.
Thank you, Alex. It's great to be here.
And lastly, and never leastly, we have Dwight. Dwight is an executive advisor at Lilac. Dwight brings 25 plus years of experience in quality and healthcare quality and doing HEDIS. Dwight has worked across a number of different plans. He led UHG's Medicaid division for doing the HEDIS reporting for UHG's Medicaid division. And he's also has been doing a lot of consulting for 10 plus years, and we are honored to get to work with him and honored to have you in today's session. Welcome, Dwight.
Yeah, and I'm happy to be here. Thanks.
And then myself, very quickly, my name's Alex Schaefer. I'm Lilac's Chief Commercial Officer. I'm going to be the MC today for all intents and purposes. And drug measures is obviously the topic for today. First thing we're going to do is just level set to make sure that we're all on the same page of what we mean by when we say drug measures. It's not just Part D, it's a little bit of a different subset. So we'll go into that and why we're focusing on this set of measures. Then we'll break down sort of the way that we look at these types of measures into three distinct categories, how they differ from clinical measures and some of the things to be aware of as an operator, and that sort of make them unique. And there are some very specific data challenges to drug measures. We're going to double click into that and go into what makes it unique, what makes it complex, and then what you can do about it. And then lastly, we're going to spend a good bit of time on just best practices. What are the things that you can do to drive better performance across these measures at your plan or your client's plans if you're a consultant. So without further ado, let's dive into the overview of drug measures. And for that, I'm going to pass it over to Mark.
Thanks, Alex. Welcome, everyone. And we just wanted to have this webinar on what we call drug measures. Again, as Alex referred to, we're really looking at basically 6 Part D measures, which we'll go through today. But we also put the statin therapy for cardiovascular disease, formerly C16, in this category as well, since the remediation strategies and some of the challenges are very much the same. Let's just back up 1 second and just talk a little bit about some of the problems we see in stars overall. And we'll tell you why we think drug measure performance is absolutely critical. So, as everybody knows, we saw a peak of overall star performance in 2022. From 2022 to 2025, we've seen a huge reduction in star power at most plans. The average overall score weighted by enrollment went from 4.37 to 3.92. It's the first time we've seen an average rating below 4 in about a decade. 68% of contracts 4 or better dropped to 40%. And what was a very huge number of 90% of weighted enrollment in 4-star or better plans dropped to 62%. And what we're really seeing is plans performance becoming very poor on both Part C and Part D. The 2025 Part C score was a weighted average of 3.52 compared with a Part D score of 3.51, so roughly the same. And in 26, when you apply the new weights in 26 to the results of 2025, the results actually drop even more. The Part C average weighted score is 3.47, and the Part D score is 3.44. So plans really have to work both sides of the fence here. The reason we think Part D is critical is it is about 1/3 of the total measure weights for 25, 26, and to some degree 27. So plans cannot really get back to 4-star or better without improving Part D scores as well. Another interesting fact is the Part C average QI quality improvement score was 3.6. The Part D score was 3.3. And you'll see right on the page here, one of the reasons we're seeing problems in the Part D world for summary scores and just overall performance is the fact that the drug measures that you see right on the screen on the left are performing very, very poorly. You'll see that statin use, SUPD, is below 3 at 2.8. But the other measures here are all sitting right around 3 or just above 3. And what's really very difficult is the fact that the med adherence measures, at least for right now and into 27, will be 3 weighted. So if those are sitting there at 3.2 and 3.3, for example, you are going to have a very hard time as a plan to get back up to this 4 weight. Compounding some of the issues are 2 brand new measures as of measure year 25, star year 27, which are both polypharmacy measures. I sort of call them drug safety measures as well. But these are very complex measures, even though they're a 1 weighting right now, but they're very difficult to really attain high levels on. And those need to be focused on as well. And going a little farther outside, we have increasing complexity and disparate measures. This will include risk adjustment on the med adherence measures and the retirement of the inpatient and SNF allowances there. So just in summary, as a quick overview, it's very important to perform on these drug measures. The ratings are very low, and that is part of why overall scores have dropped rather dramatically. If you don't perform on the 33% that are Part D measures overall and the strong percentage that are drug measures, it's going to be very, very difficult to attain 4-star or better. With that, Dwight, just wondering if you wanted to add some additional insights related to some other things on the drug measure side here.
Yeah, I just want to mention that these are worth the investment. Like we've seen plans improve the adherence measures year after year. The cut points keep moving because plans have found ways to solve those problems. If you're challenged, let me make a point. Quality improvement and now the new Health Equity Index reward, which is now EHO for all, those are easier target points to reach each year. So you got to make sure that's part of your goals and that these measures are movable, it's doable, but you got to invest because it's worth the investment because you don't get just points for the measure level scores. You get points for these other rewards like quality improvement and health equity. So I would encourage plans to invest a little bit more now.
Great, thanks, Dwight. I know, Neetu, you're going to be going into a lot of data issues, and I know data complexity is a huge issue for the drug measures as well.
That's right. We have a whole bunch of conversation coming for the data issues, and I'll wait till that one shows up. But lots of things here to improve, or very accessible things to improve, and they need some basic data hygiene. So I'm excited about that portion.
Sounds great. Well, thanks. I think what we'll do now is probably go on to the next module here. And this is my module 2 here. And we're talking about the 3 types of drug measures. And the reason we're educating a bit on this is they are, as I pointed out, very complex in general, and there's great disparity, right? So Dwight is going to go a little more into the difference between clinical and drug measures in a little while. But within these subsets of about 7 measures, including the one HEDIS Part C measure, great complexity and great disparity in how you even approach some of these measures. And later on, we're going to give you a little more about best practices we think that you can take on all of these measures. But first, let's talk about those 3 types of measures here real quickly for those less familiar. So number 1, we have our med adherence measures. We talked about these being 3-weighted right now, and we talked about risk adjustment coming into them in measure year 26 for star year 28. But here we have our med adherence for statins, med adherence for diabetes, and med adherence for hypertension or RAS antagonists. In general, a med adherence measure simply measures the consistency of members taking medications. It uses proportions of days covered, which is a PQA measure methodology, to really assess adherence and compliance. One of the big challenges here is that, again, you need to be monitoring these 3 measures for the entirety of the year. You got to start early. You got to go all 12 months. Because obtaining compliance, according to the tech specs on this one, is very difficult. You need to hit an 80% adherence rate for the year for that member to be deemed compliant. And it really allows for very few interruptions of ongoing fills over 12 months. We'll get a little more into missing refills, which are sort of short gaps, and sometimes long gaps that occur with care transitions and things like that. But the note here about the challenge is it's very, very time consuming, and you have to be laser focused throughout the entire year. I would also note that some plans are relying only on Acumen. We're going to talk a little more about that later. But again, the Acumen report lags, which complicates, getting to adherence at a very high level on med adherence. Statin usage is sort of another category here. Again, we have SUPD, which is the Part D PQA measure, and we have statin therapy for those with cardiovascular disease. Similar types of measures. It's really meant to have the appropriate use of statins in high-risk populations. And again, it's diabetes and cardiovascular disease. We see lack of education of both members and physicians as a big challenge here. The SPD measure it's SPC. We have a little typo here. Sorry about that. But that SPC measure requires moderate or high intensity therapy. So that's an additional complication. Just because you're on a statin for the cardiovascular disease HEDIS measure does not mean you're going to be compliant. And I think many plans don't realize that, and many doctors certainly don't realize that. And that's where some of the training and education comes in as well. And then the last measures here real quickly are polypharmacy. duplicate therapy, drug safety issues that can come up. So you see the two measures here, including concurrent use of opioids and benzos. So really the goal here, the description is monitoring and improving the safety and appropriateness of the use of these medications and not having duplicative therapy or overdosing. Very strict measure. The overlap of multiple drugs here, whether it's benzos and opioids or multiple anti-cholinic, I'm not going to pronounce it right, but ACHs, you're going to not have more than 29 days or less, right? If you have a script that is 30 days or more, you're immediately non-compliant for the year. We're going to tell you a little more about how to look at doing that as well. So with that, I'll turn it back over to Alex here.
Actually,
Great. Thanks for all of that, Mark. And sorry, that was a premature click, but that leads us right to what we want to talk about next. And we'll pass it over to Dwight, and he'll go a little bit deeper into the difference between drug measures and HEDIS measures.
yeah, I wanted to do a quick comparison with HEDIS gaps measures and the drug measures because there's a lot of confidence in HEDIS. It's been around a long time. So is adherence in the drug measures. But folks are still coming to me and going, hey, I'm frustrated. I'm challenged by these measures. What do I need to do? And I want to sort of look at the differences so you can get a sense of like, how do I overcome that challenge? But also, what do I need to do differently? And so one of the first and foremost ideas is that it's not unusual, but the patient safety measures, the drug measures are produced by CMS. And when you're getting those reports, that data is late. It's 2 months lag. It's in the past. It's helpful to understand because it's going to tell you what the national average is and how you perform and what your actual CMS reported score is, which is what you have to validate. But it has nothing to do with what you need to do for interventions. It's too old. HEDIS is internally controlled. You've got analysts obsessing about accuracy and data. You've got, when I ran HEDIS, like we had whole teams looking at validity of the data, looking at how fast can I get the data, where my supplemental hits. For pharmacy and medication data, it's like this other thing we're waiting on. Plans need to get access to information on a regular basis. Prescriptions are filled daily, right? You're going to have live current data to know what you're doing. So put investment in areas where you can get better, faster data so you can intervene. The other nature of this is that the gap, this idea of a gap in HEDIS is easy, right? I got a set of people. I know they need an A1C by the end of the year, a mammogram by the end of the year, a different period of time for different measures. So there's this known gap and I got to close it. Well, with these other measures like adherence, you've got the member starts out compliant and they slip over time and like miss a few days here for the fill. And then the next fill might miss 5 days. And it builds up over time to this lower than 80%. The same with these new measures. What it is like you've got an opioid, if you fill it twice and then you got a benzo filled twice and it overlaps 30 days, that's the hit, right? Members are not compliant members are sort of a hit when that all happens. You need to intervene and track ahead of that. So you're actually anticipating risk as opposed to a known gap. So what it means more is more better data, more analytics that tells you what to need to do and how you handle that. And then interventions. Let's talk about the fact that gap closure is very well known. You do outreach, you assist the member getting the coordinated care, and you document it so you can track and report it in HEDIS. For medication, it's very different. Gaps an issue. Why some members are splitting pills. Some people don't really like the medications and sort of forget. Some have cognitive issues that they're forgetting it. So you're having to overcome individual barriers so that you can assist the member and coordinate the care. And that's the same time with tracking data and trying to figure out who's at risk. And the big difference is you are reliant on the prescriber, the physicians. It could be multiple prescribers. For the polypharmacy, it could be a specialist and a PCP. So you've got to engage providers to actually help close the gap. And that's a challenge. You can use pharmacists, you can use others, but definitely it's like one of those things you're going to have to figure out, like, how do I incorporate the member's doctor into the discussion? Because you can't just call a member and say, hey, you need to be on a higher level stat. And they're going to talk to my doctor. What do you have nothing to do with this? You got to get more involved in saying, hey, alerts to the provider, say, hey, these members had a severe heart condition. We need to get them on a better stat. And here's the clinical guidelines. please work with your patients. And then finding complexity of data. I'm not a pharmacy expert. I'm not in Part D, but I've done a lot. I used to do analysis in the area. But the point of this is that you got to look at days filled, gap lists, and then also what I would recommend is you put more investment in sort of social risk factors, conditions of members' responses. Some members will be like, I stopped taking that medication. Like, you don't need to badger them about adherence for a medication there and their doctors told you they're done with, versus others who are like, I keep slipping, forgetting, they need reminders. So knowing the data and pharmacy data and what's current is really critical in that process. So hopefully all that helps in understanding what the challenges are and how those are different than from HEDIS, because then we'll talk about interventions in a little bit.
Great. Nito and Mark, anything that you would like to unpack on any of these? That we go into, it touches on some of what we'll talk about on the last slide, but anything that you feel is relevant to raise right now?
Yeah, just one point that overlaps with my earlier one about multiple prescribers, right? When you think about COB and you think about poly-ACH, think that there could be multiple prescribers there too that are involved. So the coordination with care management within the plan and multiple providers is an additional sort of thing that Dwight noted you have to really deal with.
Great. We've got a few questions coming in, but we'll address them at the end. So we'll keep it going, but we see the questions. We'll get to them. We'll make sure to get to them at the very end. So very good questions to make people excited to hear what they are. All right. Thank you for that. Nito, over to you to talk about some of the unique data challenges of drug measures.
Yeah, thanks, Alex. As we started working with plans for figuring out like what is the real root causes of some of the challenges in improving the drug measures, in addition to all of the things that Mark and Dwight mentioned already, some of the really basic ones we ran into is just like how the data flows that determines what the score is and what you take action on and what you intervene on. So just on the left-hand side, just laying out like how the data flows even to calculate what the drug measures are. We discovered very, very simply, like plans and CMS share a lot of data between like medical claims and eligibility and enrollment. The PBMs tend to have a lot of data about actual pharmacy claims and and plans have to share enrollment data with PBMs. CMS runs the drug measures, or actually captures the data and shares it with Acumen, who actually runs the measures and then sends plans the reports. All of this data movement that happens, it happens behind the scenes from like a plan perspective. PBMs and CMS doing PDE submissions, we discovered plans weren't actually monitoring if all the PDEs were in fact submitted or not. When we were looking at Acumen reports, we discovered not all the exclusions and adjustments were applied. So we've actually like come up with a solution to help plans with doing things where all of this data is in fact monitored, all of this data is captured, and the right interventions are done on the right data at the right time. And this is basically what we recommend. Like there's a lot of impact that's happening with all of this data movement on the actual scores for the drug measures for you. But if you don't have visibility into it, and if you don't have like oversight over how this data is moving, and if the right data is in the right place at the right time, there will be losses around the edges across the board. And this is beyond the fact that Acumen data is several months late. So if that's the data that you're currently using for any of the gap closures, you're already starting 2 months behind at least. So behind the scenes, this is what's happening with the data, and this is what we are helping our plans with. Dwight or Mark, any of the behind the scenes data movement challenges that you wanted to highlight?
No, I just love a picture that has diagrams going all different directions, right? I like the plans that are succeeding are taking their time to sort of self-examine their information, use analyst time, use vendor support like you need to, and others to like get at the truth and what the current information is, because what happened 2 weeks ago is now no longer relevant. So you want to have as much data rapidly through the system as possible. And
Yep.
post.
Yeah, and I would just add the medical claims aspect is an interesting one here because you don't see that usually in a drug measure, but you do have some exclusions as well as the adjustments, at least for right now. So you're not only talking about a successful PDE process that you have to govern, but you also have to team up with your encounter submission folks to make sure that encounters are making it through all the way through the system as well, which can be a problem, much like it is with PDEs.
Great, and that's a good bridge to our last slide, last planned topic for the webinar before we get to Q&A. Just best practices and what are some actionable things that everyone here can do with their plans or their clients' plans to help improve performance. So there's a long list of things that you should be doing to drive performance in the drug measures. Try to distill those into a few different categories, 5 different categories, and then highlight some of the things that we think are most important that maybe are less obvious or less commonly done that we see amongst our client base and just other plans that we talk to that really are the difference between the high performers and those that are not in that category. First category is of the types of best practices is real-time data. Neetu, fitting, you're the person to pick up on that. So I'll pass it back to you to talk a little bit about best practices around real-time data and reporting.
Yeah, thanks, Alex. The big insight here is the fact that plans who succeed are using their data differently. They're using the current data for making impact in interventions that impact current state of the member. So if you have a member who only has like 3 more days left before they fall into the numerator, you want to actually call them now. So, and you can't wait for the Acumen report to show up a couple months later to discover that the person's also in the numerator in addition to being in the denominator. So the first recommendation is just run the measures yourself, have your own point of view, do it on your current data, and actually just go after interventions immediately. Don't wait for Acumen reports. I'll pass it on to Dwight.
Yeah. I'm going to talk about member strategies. When we talk about best practices, often what I'll say is that there's a lot of plans, and when I do consulting, I often have an idea. It's really about implementing it well. So you're really wanting to have a stratification of risk because you can't possibly call every single member in your adherence measure and the like. So you're going to have to find ways to pick and choose who gets what type of level of intervention. I've seen good success where plans do nudges and then they only do live calls for people that are like more problematic. A lot of plans focus and obsess about the members that are between 70 and the 85, right? Like right on the cusp of adherence, recoverable and not, might be slipping. You can certainly pick that. The 90-day, supply was the classic. That's if you haven't done that and making sure every member switched over. I have heard one plan after plan talk about 100-day supply not working. And then I just had a client talk about how 100-day supply was working for them. So certainly you're going to want to expand ways to make the medication automatic and delivered and available. And it's all about direct engagement with members and solving individual problems. I think the more you can do information gathering when you're having a conversation, whether it's a case manager or pharmacist or other program, and they give you feedback, it's incorporated into your strategy so that you can respond right to the right people, whether they're pill splitting or they have other issues that need to overcome, so you solve their problems. And when I talk about provider strategies, I said before, like first and foremost, your prescribers are front and center to these measures more so than the, measures that you can send them to a lab or get a service direct through a vendor. So you've got to give them the right information in the right way they can have it. Certainly, there are some EHR tools that have flags and system tools, but a lot of plans don't have control over their whole network and how which EHR they're using and how to flag that. So what I would suggest as a best practice is finding ways to hone in on who's truly at risk and not send huge gap lists and long lists that the providers can't get through. You need them to focus on very specific individuals that have a clinical quality risk problem and say, hey, focus on these 12 people or these 50 people, depending on the size of the practice, and get them focused in a way that they can actually assist you in addressing those individual members' challenges and find the ways to like link that. Incentives always work with providers, and the right reporting tied to incentives is going to make it work. They want to do the right things clinically. They're challenged with time with their patients. Patients are going to different prescribers. So the multi-prescriber reports often help to say, hey, provider, they're getting their prescriptions here and here. You might want to get that addressed through a med review, med list process. And I find that pharmacists educating providers and or the other medical office directors at the plan working with clinically directly with the providers has a better influence than regular staff sending lists and saying, hey, close these gaps or address these 20,000 members. It's definitely important to have the right people talking with the providers with the clinical information needed.
Great. Yeah. Mark, pass it over to you to go into how plans can best practices around leveraging the entire enterprise.
Great. Yeah. And I think this is oftentimes somewhat overlooked, right? Oftentimes outreach on these drug measures are confined to maybe just a pharmacy unit or something like that. But we really recommend that you look very, very broadly on this. And by really assessing the barriers to care that these individuals have, it could be financial, it could be socioeconomic, it could be a health literacy, it could be those kind of issues. They could be a medically complex type of individual as well. And I think the more you can assess exactly the profile of that member, the more you can actually leverage different areas of the health plan. Now, you still may do a broad outreach to these individuals, but if you're finding that they are not really responding and their adherence rates or things like that are not going up, even on an escalation basis or even holistically, you get other departments really involved. So if they're an MTM enrollee, get the MTM folks involved. If they're a SNP member, you could even look at getting the special needs plan folks involved by embedding some of these challenges into the HRAs and care plans. Care transitions, I would really emphasize as a very important part here, right? We know that long gaps occur when medications that are ongoing are not started again timely, post, for example, a surgery or something like that. So make sure you coordinate very closely with care transitions as well. I'll turn it over to Nitu,
Yeah.
I think, to close this out here.
Bringing it full circle, we have the book ended with data. Use the real-time data as much as possible, but that doesn't change the fact that eventually the scores are calculated by Acumen, and we highly recommend, and this is what we help our plans with, is once the Acumen reports come out, we have to verify them. You have to verify that they actually accurately represent what the actual plan's data is and what the plan's view is. So recommendation around validating all the PDEs that should have been submitted are submitted. So accuracy and completeness of PDE data, reconciling enrollment and eligibility with PBMs. Did you happen to have disenrollment or additional enrollment or eligibility changes that maybe didn't get to the PBM that they should have gotten to the PBM? And similarly, there might be discrepancies that CMS has in terms of what is accounted for in exclusions or what is accounted for in adjustments. Just lots of reconciliation between the two data sets of your own point of view and what CMS or Acumen thinks should be the right one. That's the last recommendation here. It's important to use the right data, but it's also extremely important to verify and monitor that the the data that CMS and Acumen has. And in fact, CMS has a couple of like several times have recommended that plans come back and do appeals and fix the data if they find any discrepancies. So actively going to look for discrepancies, and if you find any, push to fix them.
Yeah, I would say that you have this month to notify CMS of concerns of the data accuracy in your reporting from last year. You have only through June to actually correct PDEs that go to CMS for the reporting. But it's, if you have the time, I know a plan that reported errors in July past the due dates and deadlines. And CMS said, sorry, that's, you were told you have deadlines. So you do need to look at the HPMS policies for deadlines for notification and not have late findings of data concerns. So you have several weeks to do that right now. I would encourage you to think about that if you're 1.5% the next star level or something, then you want to at least investigate that. You have a few weeks to do that right now.
And I would also note, in addition, that you could have error, the CMS side could have errors, and those are clearly things you have to go after and even appeal. But it could be an error on your side that could reduce the PDC, for example, or an exclusion, for example, here. So remember, you may need to remediate on the plan side too to boost your scores, in addition to remediating CMS issues.
Yeah.
Great. Very, very practical final suggestions. And actually, before going to the Q&A, I'm going to ask each one of you, just across all the categories, if you had to highlight one thing, let's just limit it to one, of a best practice, something that's maybe either less obvious or is less commonly done, that you think is most important for the listeners today to do what they're planning, to try to marshal resources to do. What would that be? Dwight, I'm going to pick on you first. What would be the one thing that you would recommend, a best practice that you recommend that is less obvious or just less commonly done?
Yeah, I can't do just one. But
Yeah.
First and foremost, the timing of your start, I don't need to be mean to people doing plans, but if you're just starting a project for adherence for this 2025, it's late. You have to work a plan for the first quarter when the members are starting out, getting their fills and their strategies so that you understand who your members are and you're working with them from January through. I often see people wait for the patient safety reports that just came out around last week, till they start really taking a new action. And then they treat it almost like gap, and again, HEDIS gap closure at the end with trying to close it out. And I find that wherever you start, that trend tends to be very similar. So you want to start higher in your adherence. So starting early matters. The same goes with your new measures. You have members that are on opioids that aren't yet on benzos, and you need to figure out who they are today and then work out a strategy over the next couple of weeks to say, how can I make sure I educate and address the fact so they don't get those fills from a different prescription provider in the next week or two. And I said before that the goals can be minimal, meaning statistical improvement or the like, and you can certainly set yourself up for being success in that way and not have to if you're so far from a next star level, quality improvement impact is worth it.
Good. Nitsu, we'll go to you next.
Yeah, I'm on similar camp as Dwight. Unlike he is, the gap closures in these measures don't only just have the actual gaps, they have a deadline. You have to close them before a certain amount of time, or you have to identify what might be a gap and close it beforehand. So if there's only one thing you can do, I would say operate on your own data, get control, have the list of gaps that you're trying to close under your own control. Don't wait for the data to meander over from various different places over to you before you address gap closures. if you've closed the gaps, you can always go back and fix the data. That does have a deadline, but it's a much longer one. But the actual gap closures, they should be timely. So I'd say don't wait for acumen. Figure out what the gaps are beforehand and close them.
Great. And to end where we started, Mark, why don't you give your recommendation, then we'll get to the Q&A.
Sure, I'll do two quick things. One,
Okay.
as Dwight said, at-risk members are probably the most important people to track for COB and poly-ACH. But don't forget and don't ignore the people that are non-compliant now or had the duplicate therapy, because you got to fix them for the following year. So I would make that point. It's real easy to say, well, I shouldn't go after this guy because he's already counting against me. You should proactively take care of it, because they will not hit the numerator in this case in the following year. I would also say look at the IRA changes. I think the more you can look at some of the data related to cost sharing, whether it's LIS or non-LIS members, that might be very good, because the landscape is changing with the IRA changes that makes co-pays and cost sharing overall go down a bit over time. It's a little bit cyclical and things like that. But look at the data and recommend to your members strategies if they are saying they have financial affordability type of issues as well.
Great way to cap the best practices and recommendations. Thanks everyone for that. We've got a few questions. I'm gonna read them out and try not to jump around too much, as the Zoom control panel is a little bit fickle. But all right, first question: for medication ADH for diabetes, how do you suggest health plans manage GLP-1s members falling into measure for weight loss? Mark,
Yeah, so I think it's a great question. Technically speaking, the drugs will not be available just for weight loss, but it is very possible that people could be on it for it anyway, right? We won't see the widespread proliferation.
There's no diagnosis data for this measure, so it's based on medication usage. So what I'll just correctly state that everyone's in the same boat, right? Like, so you won't be able to exclude members like you used to with HEDIS and like fix the diagnosis. You can't take that out, but you can work on adherence tracking. I think you're going to see that affect results over time. So the cut points should adjust to that change. So I always talk about the fact that like when something's not a plan specific problem and it's a new thing that's like national and everyone's affected, you might be a little bit more affected than someone else, but it should affect everybody. So what you're newly challenged with, and you have two questions on there about this. I think that you're going to have to focus on keeping people adherent to the medications that put them into this measure. And it might be an incorrectly labeled person. Hopefully you all can also send CMS notifications that this methodology needs to be corrected, and that there should be a way to take members out that don't have the diagnosis.
That's right.
Right now, that's not allowable.
Yeah. But I think you got to document it, right, Dwight? Because that could be an issue over time.
Yeah, I would think that this is one of those plan preview responses that I would be writing, where I might go to particularly plan preview 2, but even I might bring it up in 1 if I'm concerned, and say that, my score is 62%, and if I looked and did an assessment and this many people are on GLPs and I cannot find any reference to diabetes, and my score should be 64. And then during plan preview, if you're losing a star level because of that one difference, I would be putting in my plan preview 2 response. It doesn't mean you will get the result, but at least there is another angle to go back and argue differences, because it's not really fair, and it's just like other times in the past when measures methodologies haven't kept up with the clinical changes and behavioral changes of services. So I think we have to fight this one over time, but for the time being, I tend to take the perspective that every plan will be fighting the same thing. Continue to focus on maximizing your adherence completion for all the members. And then if you have time, do that kind of analysis of impact, report that to CMS.
Yep. And I think another person also raised the issue that they could be on a GLP-1 for cardiovascular, right? So you also have to document those. So document if it's weight loss, although since it hasn't been extended just to weight loss, that won't be a big issue. But I think the person that raised the issue of taking it for cardiovascular disease is also, that's pretty significant as well. So document and see where this goes over time. So I think even if you don't win appeals, putting them in tends to make sure that CMS looks at these issues over time.
Yeah.
One other issue on risk adjustment, real quick, Alex. We agree with the questioner that said there's not a lot of information available. We have asked CMS for exactly how you are calculating the risk adjustment for the adherence. We know that it's age, it's gender, it's dual eligibility, LIS, and disabled. But again, similar to like your CAPS case mix, it's a bit of a black box and we don't know exactly how that's done yet. We think they should provide it. However, the fact that they're doing the reports now and they are showing you on the display reports those rates, we think it's important for you to drive the adherence in these categories because that will have the halo effect of driving up the rates overall.
Great. And just for reference, someone asked about risk adjustments for next year and how it's calculated by CMS and what can plans do to proactively gauge their performance beyond just using the data that's coming through with the display data. So that's when we're all navigating and just trying to learn on the fly. One more question that came through is, have you seen any instances where the first Acumen report results are low, but jump back up with a second release? What might cause this?
This happens a lot and it's pretty dramatic. So like, don't get too despaired or challenged by your first month's results that just came out. It's two reasons. There's a lag in data and the timing of the data. Remember, they have to have two fills to be in this measure, like adherence, right? So what happens is that's depending on when their first fill was of the year and the second, and whether they fell in and look at here, it does affect the analysis of adherence. And so I would say it's typically that methodology of two prescriptions, the data lag. And I've seen it time and time again where plans have an odd number and then it sort of stabilizes and then it goes about its normal trend from there. But yeah, and then sometimes there's bobbles at the end with data correction and an adjustment based on his claims lag as well. So keep an eye on your monthly data. You should be able to see it in the detail too. Remember.
So it's important to have like a picture of what happened 2 months ago with your Acumen reports, but also work the cases based on your current data in your plan.
Yeah. Thanks, back to
that. Like if you're doing what Neetu says, like if you're working on based on your current pharmacy data and not CMS reporting, you're much more accurate and CMS's reporting should eventually catch up.
Yeah.
Right. And then if it doesn't, then you're doing a data validation like we talked before, which is literally looking at whether your prescription data is getting fed to CMS through the PDE required submissions, which if you talk to your pharmacy team, if you're not familiar with that, as well as the current exclusions and whether the claims data identifies members like in hospice correctly, which eventually will go away as well in the methodology. So, keep up to date on methodology changes as you do the analysis. They keep changing.
It's a bit like looking at the Cosmos, right? What PDE tells you what happened 2 months ago. Like Acumen tells you what happened 2 months ago. Just like you're staring at a light of things that happened eons ago.
Good.
That is a wonderfully nerdy analogy.
Thank you.
Good way to wrap up. I think that's it for the questions, and we're at time. Give people a little bit of break before their next meeting or lunch or whatever they have next. Thank you very much for joining today. I hope again that it was useful. If you want to learn how Lilac can help you out with any of these things, please check out the website, reach out to us. Even if it's just exploratory, you might be able to tell we like to nerd out and get deep into data challenges, operational challenges. So always happy to just explore and give our best views on what can be done, just as a baseline conversation. There will be everything coming as follow-ups within 1 or 2 business days, the recording, the ability to download the deck, and a summary of the content. So thank you very much. Everyone have a great rest of your day, and thanks for joining.